Welcome, welcome. Good morning, good afternoon, and good evening to everyone. Welcome to the World Breastfeeding 2025. Today's webinar, Building Healthcare Systems That Truly Support Breastfeeding. New Tools for Sustainable Change is brought to you by WHO and UNICEF in partnership with the Global Breastfeeding Collective. I am Dr. Altrina Mukuria-Ash, and I am delighted to be your host, to be your moderator today. And thank you all for joining us. I wish I could see where you're coming from. Joining us today for this important topic. Before we start, I'd like to remind everyone about some housekeeping issues, Next slide. Interpretation. The webinar offers interpretation in Arabic, Chinese, French, English, Spanish, and Russian. And to switch languages, you should click on this symbol here, and you can switch languages. If at any point during today's webinar, you're unable to hear the speakers, please make sure you're connected to your audio by selecting the headphones icon. And if you choose to listen in English, when you hear another language, then you have to go to the interpretation channel for English, okay? Next slide. Closed caption. We have closed caption has been enabled for this meeting in English. And to view the English subtitles on your screen, click on the little CC icon and select the show subtitle, show the subtitle. Next slide, questions. Please note that this webinar is being recorded, so submit your questions in for the panelists in the Q&A box. You see we've circled it right there, and direct your question to a particular panelist. The panelists may reply to your question via the Q&A box, or will answer your question during our live Q&A towards the end of the webinar. So our goal today is to strengthen the quality and the sustainability of breastfeeding support in the health system. Let me set the context for you a bit. I'm sure you agree that embedding skilled breastfeeding support within the healthcare system is essential. And this is essential for maternal and child outcomes and for building stronger and healthier communities. The Baby Friendly Hospital Initiative has made strides in integrating lactation care and support into the health system. However, after over 30 years of implementation, we've learned that in order for breastfeeding support and care to be sustainable, we must ensure that a multi-sectoral, whole system approach be used, starting with the health system. WHO and UNICEF developed revised guidance in 2017 and 18 that looked beyond implementation to the enabling environment and governance for scale-up and sustainability. Today, we have an exciting lineup of speakers who will take us through 3 new updated tools and 4 panelists who will share their country and regional experiences with engaging healthcare systems and beyond in order to strengthen the delivery of breastfeeding support. Our goal today is to familiarize you with these resources and encourage countries to strengthen their healthcare systems to truly support breastfeeding. A few years ago, a group of us did a study of the Baby Friendly Hospital Initiative, looking at progress towards institutionalization of the 10 steps, sustainability, and scale up in the Kyrgyz Republic and Malawi. We found that tools and curricula were needed for pre-service and in-service training of medical professionals, that health professional associations wanted to and were willing to play a role in monitoring and assessing the competencies of their members around breastfeeding support, and that there were gaps in prioritizing, funding, and monitoring breastfeeding counseling and support. Now, today, I personally feel that this webinar was designed for me to learn about the response to our findings. And I'm sure some of you who have been working in the field also are eager to, and looking forward to these new tools that will be presented to us today. Together, let's strengthen the quality and sustainability of breastfeeding support in the health system. throughout the continuum of care, from the womb to up to 2 years and beyond. Next slide. Our agenda today, as you can see here, was quite packed, and we're going to try to get through all of it. We'll start with opening remarks, followed by a powerful video featuring voices of mothers, because their experiences are the heart of why we do what we do. Next, we'll explore 3 new tools to support breastfeeding in healthcare systems: the Baby-Friendly Hospital Initiative Monitoring Manual, the Competency Verification Toolkit, and the updated model chapter on infant and young child feeding for medical textbooks and allied health professionals. After that, we will have a panel discussion where experts from Ecuador and Mexico and Honduras and Zimbabwe will share their country-level experiences of integrating breastfeeding support into healthcare systems. And then we'll open the floor for your questions and answers and close with a call to action. Next slide, please. We haven't, I already told you that. It's my pleasure today to introduce to you our opening speaker, Dr. Maji, who will be welcoming us to World Breastfeeding Week 2025. Dr. Joan Maji is UNICEF's Director of Child Nutrition and Development. She has over 20 years experience in public health and nutrition. Dr. Maji previously worked in as the regional nutrition advisor for Eastern and Southern Africa, where she provided oversight for UNICEF's nutrition programming in 21 countries. And she served as chief of nutrition in Ethiopia. Dr. Maji is a national of South Africa and holds a PhD in public health and public health nutrition from the University of Pretoria. So I turn it over to you, Dr. Maji. Welcome.
Thank you so much, Altrina, for that welcome and introduction. Greetings, everybody, from UNICEF headquarters in New York. Good morning, good afternoon, and good evening to everybody across the world. As Altrina has mentioned, we have participants from all over. I'm absolutely thrilled and honored to join you today and address you as UNICEF's Global Director for Child Nutrition and Development, and importantly, to welcome you to this important global gathering. Together with World Health Organization and the Global Breastfeeding Collective, we are marking World Breastfeeding Week 2025, which is a significant time for us to reaffirm our commitment to breastfeeding as the cornerstone of child survival, health, and development. The theme this year, which is Prioritize Breastfeeding, Create Sustainable Support Systems, calls for lasting investments from governments, systems, partners to better support mothers and their children. Ladies and gentlemen, colleagues, we have seen remarkable progress in global breastfeeding, in global rates of exclusive breastfeeding. We know that these rates have risen by more than 10 percentage points in the last 12 years, currently standing at 48%. We have to move to get that extra 2%. This shows that when we scale up proven interventions, real progress is possible. We should not be complacent, though, as we are still short of the new 2030 target of 60% exclusive breastfeeding. And this definitely underscores the need for sustained investment and actions. And it'll be very interesting for us today to listen to the experiences from countries on some of the actions that they are putting in place to catalyze our commitment to promoting breastfeeding across the world. Ladies and gentlemen, colleagues, breastfeeding is one of the smartest investments we can make in a child's future. When mothers receive timely and skilled support, they are more likely to initiate and continue breastfeeding. Early initiation within the first hour of birth and continued breastfeeding for up to 2 years or beyond offers vital protection against illnesses, mortality. It lowers healthcare costs and strengthens outcomes for children and mothers alike. Breastfeeding, ladies and gentlemen, colleagues, is not just a personal decision. And I say that not just as a public health expert, but as a mother who has breastfed her 2 children. It is indeed beyond a personal decision. It is a public health imperative and a shared societal responsibility. Every mother's breastfeeding journey is unique, and our support systems must reflect that diversity. Today's webinar will highlight practical tools and country experiences that show us what works in different contexts. Most importantly, we will hear directly from mothers themselves. I'm excited to listen to the video and the stories of mothers themselves. Every mother's experience and journey is different, but their stories provide valuable insights into the barriers they face and the support they need. It is these important voices of mothers which should inform and shape our strategies as a global community and also the policies that we come up with. UNICEF and WHO call for stronger investment in maternal and newborn care, with breastfeeding support as a core component. We must ensure healthcare providers are trained and supported, especially in emergency contexts. And colleagues, I'm sure you're seeing the emergencies all over the world that are happening at a very large scale. We need to ensure that we are providing support to those most vulnerable mothers when breastfeeding is indeed a lifeline. UNICEF stands committed to working hand in hand with all of you and partners to ensure that that children receive the best possible start in life. I wish you all a great and enlightening session that will reignite all our energies towards promotion, support, and protection of breastfeeding wherever we are. I thank you for your attention, and now back to you, Altrina, to take us through the rest of the day. Thank you.
Thank you so much, Dr. Maji, for those inspiring remarks and for setting the stage for us beautifully. You really put us right in the right place. Thank you. And your words remind us of why we do this work and why it's so important for mothers, children, and families worldwide. Thank you again. So next, we have the voices of mothers. We get to hear from moms themselves. That's why we're here today, to talk about how we can best ensure that mothers have the support that they need to reach their infant feeding goals. What better way to kick off our webinar presentations than to hear from mothers themselves? Let's go to the videos.
J'ai réussi à allaiter grâce avec toute l'équipe qui était formée et qui répondait à mes demandes, à mes sollicitations jour et nuit avec beaucoup de bienveillance.
Mình đã cho con trai ti được 39 tháng rồi, bởi vì mình đã cho con ti được ngay từ những ngày đầu tiên sau khi sinh, cho nên hành trình cho con ti mẹ thực sự là rất đơn giản. Mình mong rằng là tất cả các nhân viên y tế đều có kiến thức đúng về sữa mẹ để có thể hỗ trợ những người mẹ có hồ cho con ti đúng ngay từ những ngày đầu.
Mothers around the world want to breastfeed. They need support to make that happen.
When I had some difficulties, they said, you'll do that, don't worry, you will do that.
كنت أعاني من قلة إدرار الحليب، ومع أخصائية الرضاعة أعطتني بعض الإرشادات والتوجيهات من ضمنها خطوات فعالة لزيادة إدرار الحليب.
The pediatric doctor came to assure me about my preterm baby's 26 weeks, and she told me she just need 1 ml from the colostrum. Since that time, my baby complete her breastfeeding journey for 2 years.
Breastfeeding support in healthcare systems is essential. When it's missing, mothers and babies pay the price.
The help I wish I had from healthcare providers is advice on breastfeeding, physically showing me how to do it.
32 ngành dược sĩ, đa số những dược sĩ cùng nghề với mình chưa được cập nhật những kiến thức đúng về sữa mẹ.
Unfortunately, I had a lot of misinformation that confused me.
분만실에서 간호사 선생님이 제게 모유 수유를 하면 아가 체중이 줄 텐데 괜찮나요? 라고 물으시길래 제가 무척 혼란스러웠던 기억이 있습니다.
Los pediatras me dieron una información errada y me dijeron que debía darle de lactar a mi bebé cada 3 horas.
아기 태어나고 완전 모유 수유 희망한다고 했었는데도 굳이 3시간 아니면 새벽에는 콜 없이 분유로 수유했던 게.
However, with the right training, healthcare workers can change the story for mothers, babies, and families.
I had lovely nurses that sat with me, helped me to breastfeed, encouraged me.
ولدت ولادة قيصرية أعطوني إياها ورضعتها رضاعة طبيعية نسبة لأنها هي بريتيرم النيرس علمتني أختصر الحليب.
Cảm ơn nhân viên y tế được hướng dẫn tự bú đầu tiên và được hướng dẫn về ý nghĩa của sữa mẹ.
ባለሙያዎች አሁን አገልግሎት የማገኘው ከ10 እስከ 12 ጊዜ በቀን መጥባት አለበት ልጁ ሌሊትን ጨምሮ ማለት ነው።
Na zo asibiti awo ma'aikatan lafiya suka bani shawara. Yaro na ya tashi da kuzarin jikin shi kuma ba cututtuka.
ogeessonni fayyaa waa'ee haadha barumsa adda addaa naa kennaniiru.
ولله الحمد من قبل ومن بعد تمكنت من إرضاع أرشدتني إلى أهمية الرضاعة الطبيعية وكيفية مص الطفل للحلمة.
When staff have the training to help, mothers feel fully supported, even when challenges arise. What ensures every parent gets that kind of care? Evidence-based lactation training for every healthcare worker who supports mothers and babies.
Hoàn toàn trực tiếp nhờ sự hỗ trợ của đội ngũ tư vấn viên sữa mẹ, mình đã vô cùng biết ơn tất cả mọi người.
Agradezco mucho todo eso y valoro mucho.
It just made all the difference with all 3 of my babies.
កូនដោយទឹកដោះផងដែរខ្ញុំសង្ឃឹមថាបងប្អូនស្ត្រីគ្រប់រូបនឹងទទួលសេវាកម្មនៅមន្ទីរពេទ្យ
da shawarar da ma'aikatan lafiya suka bani a saka da aiki.
Muna godewa Allah ya ci gaba da
muna godiya sosai akan shawarwarin da suke ba mu Allah ya saka da alheri.
والحمد لله زادت نسبة إدرار الحليب لدي. شاكرة قسم الرضاعة الطبيعية على مساعدتها وفي الاستمرار على.
Gracias por todos los retos que pudimos superar juntas.
Nhưng chúng tôi không thể làm điều này một mình.
Want to improve breastfeeding outcomes and community health? Invest in lactation training for all maternity staff within your healthcare system. It's the most powerful step you can take.
Cảm ơn nhân viên y tế.
Tất cả mọi người.
សូមអរគុណ
Wow, wasn't that moving? It was so great to hear from those mothers. I am in my semi-retirement working as a lactation counselor, and I hear that there's a mom I'm going to see tomorrow who's having problems with latching. It is so important, as the mom said, that we have health workers who can provide this support to them. And it's so great to hear from them. What better way to kick off our webinar? Thank you so much, mothers who shared your time and your experiences with us. It's really real when you hear from the moms. This is the heart of our purpose today, to explore the tools that can help make this vital training a reality in healthcare systems worldwide. Next, I want to introduce you to the tools that are going to help with making sure that we can scale up that training. And we're going to start off. Let me introduce our 3 speakers. We are all familiar with the Baby Friendly Hospital Initiative and the various tools on the 10 steps to successful breastfeeding. However, to ensure sustainable healthcare system changes, tools are needed at every level to improve the adherence to the 10 steps at the facility and national levels. And today we have Ms. Fatmata Fatima Sese. She will present the Baby Friendly Hospital Initiative Monitoring Manual. Ms. Sese is a nutrition specialist, infant feeding, child nutrition, and development within the Department of Infant Feeding, Child Nutrition, and Development at UNICEF headquarters in New York. She manages the infant feeding portfolio and contributes to UNICEF's global leadership in early childhood nutrition. She has 18 years experience. Fatmata holds a master's degree in public health from London School of Hygiene and Tropical Medicine and a master's in nutrition and dietetics from Jala University in Sierra Leone. Then we have Dr. Lawrence Grommerstrom, who will present the Competency Verification Toolkit. Larry is the unit head of the Food and Nutrition Actions in Health Systems at WHO, where he leads the Baby Friendly Hospital Initiative and Global Breastfeeding Collective. With over 20 years at CDC and 180 plus scientific publications, he brings extensive expertise to ensuring provider competency. And our third speaker will be Dr. Nina Chad. She will present the updated model chapter for medical textbooks and allied health professionals. Nina is a public health specialist with over 20 years experience in infant feeding. As a WHO consultant, she leads technical work on infant and young child feeding and has played a key role in developing competency-based curricula for health professionals. She's a qualified breastfeeding counselor, woohoo, master trainer, and curriculum designer. Welcome, Ms. Fatmata.
Thank you so much, Alcina, for that introduction. Colleagues from all over the world joining us today, I am honored to present to you the Baby Friendly Hospital Initiative Monitoring Manual. As you may have already seen in the winds, we recently published earlier this year, UNICEF and WHO released a new BFHI monitoring manual. And this manual basically complements the UNICEF and WHO implementation guidance, which was released in 2018, and emphasizing the importance of robust data management systems to support continued quality improvement and adherence to the 10 steps to breastfeeding. The manual basically aligns, next slide, please. The manual basically outlines 3 levels of monitoring, each critical for ensuring quality of care. We have one, which is the internal monitoring, which is basically conducted by maternity care facilities to identify the gaps, track progress, and inform external assessment. Then there is also the level of monitoring, which is external monitoring, are usually led by independent oversight bodies to verify adherence to the 10 steps as well as guide corrective actions. Then a third level is the national monitoring used for broader program planning and evaluation of breastfeeding practices at scale. And the bottom line here is across all levels, monitoring should really drive learning and taking corrective actions. Next slide, please. So what is it that's included in the manual? The manual offers indicators which are tailored to each level of monitoring. It also offers recommended data collection methods, tools with their strengths and limitations so that countries can really assess what fits the context and be able to select the right monitoring option. Then there is also guidance on data processing and analysis, as well as sample questionnaires, which can be used and also adapted to fit each context. And who is this manual for? It really supports quality teams within maternity facilities, regional bodies overseeing prenatal care, the national health leaders shaping maternal and newborn care. Next slide, please. So basically, I'm just going to go through the various levels identified here. One is the internal monitoring and the options that we have offered in the manual. We all know that internal monitoring is essential for sustaining the quality improvement and is typically led by facility managers. The options we offered in the manual are 1, maternal discharge and follow-up surveys, because we know that this captures the true experiences of mothers, and ideally at discharge, it gives an opportunity for a short recall period. We have also embedded an infant feeding exit survey in the manual, which can be used independently or can be used in the context of broader surveys. Then another option included is the routine administrative data, which many facilities use in any way to collect data on indicators like antenatal counseling, early initiation of breastfeeding, etc. But the systems may need to be adjusted to align with the BFHI indicators. And then we also have a third option, which is the medical chart reviews, which basically look at electronic paper records and can be reviewed periodically. And facilities may be able to adapt forms to capture relevant data that can be effectively used. Next slide, please. So for the other level of monitoring, which is external, done by oversight bodies, the 2018 implementation guidance calls for external assessment of systems to ensure that facilities are adhering to the 10 steps. And key options included are in the manual cover the review of internal monitoring reports, like I earlier mentioned. This is useful where internal systems are in place but limited in assessing policies and staff competencies. These are basically steps 1 and 2, but they can assess steps 3 to 10. And then there is also an option for independent data collection on clinical practices. These are basically steps 3 to 10 and necessary when internal monitoring is weak or absent. And then oversight bodies may also support in data analysis here. And then another option offered in the manual is desk review of documents. This is very critical, especially for steps 1 and 2, because it includes reviewing policies, protocols, training records, and meetings, and may really offer very critical insights on the adherence to steps 1 and 2. And then there is key informant interviews, which gathers insights from staff on implementation of practices. And then site visits, which cover direct observation and offer opportunities for supportive supervision, as well as providing hands-on technical assistance and support. But the overriding pitch here we want to share with you all is a combination of methods is recommended for comprehensive oversight, because not one size fits all. Then the last level of monitoring, which I'm going to run through quickly, is the national monitoring. For the national monitor, can we go next, please? The next slide. For the national monitoring, this really builds on data from internal and external sources and supports program level evaluation. Options will include, as described earlier, on the maternal discharge and follow-up survey, which can be done at a national scale to really provide high quality information on the 10 steps and their implementation. And national authorities could access data directly collected at facility level or through external monitoring. And then we do have the population-based surveys, example, the DHS mix and others, and then the facility accreditation supervision records, which are aggregated results from periodic assessment and provide a moving average of the 10 steps implementation. And then key informant interviews, which is basically seeking insights from staff as described in the manual. The key informant interviews or surveys can provide in-depth understanding on how the 10 steps are implemented in facilities. So with that, I will hand over to Larry for the competency verification part. Over to you, Larry. Thank you.
Thank you so much, Fatmata. That was a wonderful presentation. Good morning, good afternoon, everyone. So this webinar is about health systems that can truly support breastfeeding. And if they're truly going to support, it means that we need to have healthcare staff that actually have the competencies and the skills that they need to provide good support for breastfeeding. So I'm happy to be talking today about a new tool that WHO is putting out in the Competency Verification Toolkit for breastfeeding. Next slide, please. Now, by way of context, the Global Breastfeeding Collective that is sponsoring this webinar today has set forward a set of call to action on a number of areas to improve our support and protection of breastfeeding. And one of those is to improve access to skilled breastfeeding counseling as part of our programs and health facilities. Next slide, please. But how are we going to know that people are skilled? When we look at WHO's guidance on breastfeeding counseling, how do we actually provide this support? We had a new document that was published in 2018 by WHO that really tried to call for a more structured, periodic approach to really look at breastfeeding counseling at multiple contact points. Whereas prior to this, WHO really had kind of just talked about breastfeeding support as needed when mothers come in asking for help. And this was really a new paradigm shift to think about, no, there are critical contact points. We actually need to be providing counseling to mothers during the prenatal period, in the perinatal period, and postpartum following up out until 2 years of age. And so there's an ongoing continuum of care that we need to provide this support throughout, as I said, with at least 6 contact points. Next slide, please. There are a number of reasons why it's important that we think about these 6 visits. Each of them have different needs for what kind of support is needed for the mother, different messages that she needs to be receiving at different points in time, different challenges that she's going to be facing with breastfeeding. And so we need to make sure that the staff that are working in antenatal clinics have the skills that they need there, but it may not be so critical that they have the exact same skills as people who are working with a mother of a 1-year-old, or who are working in a hospital or a maternity clinic. These structured touch points change our thinking. It's no longer about if the mother comes to us, but it's actually our being prepared to provide that assistance in a much more proactive way. And so we need to be much more systematic about our healthcare systems, also meaning that we need to be funding the kind of support and giving people the time in healthcare to provide those services. Next slide, please. So WHO recognized this need to really understand more about competency in its revision of the Baby Friendly Hospital Initiative in 2018. It was really a paradigm shift in how we think about training. It's not training for the sake of training, having people just sit in a classroom and go through a course that may be a competency-based course. It's the right kind of information that they ought to be getting. But that in fact, if we don't check that people have absorbed the skills and are actually able to confer what they have been taught in those trainings, it's not good enough. There's no point in just being told what you should do. You actually have to be able to demonstrate that you have those skills, and we need to therefore to assess your abilities to do so. So in that guidance, we called specifically for a change in how we think about step 2. It's no longer about sitting in a 20-hour course, but it's actually about the responsibility of the facility to ensure that their staff actually have the knowledge, competency, and skills to support breastfeeding, and that they're actually equipped to do so. We also talked about a national responsibility that prior to going to the facilities, the country itself and the Ministry of Health and the partners that they work with are ensuring that healthcare professionals and managers are actually able to implement the 10 steps in that context, even before they go to the facility. So it's a shared responsibility. Next slide, please. So in that context, WHO worked with external partners to develop a competency verification specifically for the Baby Friendly Hospital Initiative. And we actually launched that exactly 5 years ago during World Breastfeeding Week at one of these webinars. It was a competency framework that described core competencies, 16 of them, with performance indicators for each of them, and a whole series of tools. That's why it's a toolkit. It describes how to do this verification, what the examiners really are responsible for, all the information that they need to have as an examiner, and then various tools for actually applying this in practical situations. Knowledge questions for multiple choice, case studies for actually looking at how would you deal with this particular circumstance, and then observational tools to have the healthcare providers working with actual mothers and observing how they are doing in providing the care that's supposed to be provided, noting what they're doing well as what they're not doing so well, and making direct observations of that, direct notes that they can then assess, can this person actually provide the care that they ought to be providing? Next slide, please. But recognizing this broader context of how we have to actually provide competencies during antenatal care and postnatal care, we recognized that we needed to expand beyond just competency for the Baby Friendly initiative, but really for breastfeeding across the board. And so we opted to work with the Baby Friendly Initiative, the Baby Friendly Hospital Initiative Network, that developed a multinational expert group to really create a broader set of tools. They built from the experience of using the toolkit in maternity units and applying it in a number of different countries, and taking the lessons learned from what was working well and not working so well, and then expanding that into the skills that are also needed for antenatal and postnatal care. simplified it down to a fewer number of competencies, and expanded some of the performance indicators to actually get at the key performances that are necessary in this broader continuum of care throughout the 1,000 days experience. The new toolkit has a much larger set of case studies to work through, because we recognize that we really needed to shore up not just the knowledge component, but have a whole lot more about how you would actually work with real situations, and many more observation tools to look at different kinds of experiences that a healthcare provider would actually be working with mothers on in their services. Next slide, please. So I just want to close with some comments about how this toolkit can be used. It's certainly important for the competencies of new staff. So at the clinic level or at the hospital level, when you're hiring someone new, do they actually have the skills that they need to provide the support that mothers should be receiving? It is also relevant in continuous quality improvement cycles, assessing how people are doing over time. In your unit, are they actually providing the care? Even if they're not a new staff, do they have the competencies that they should be doing? And if not, setting up ways to actually provide the education and correction of those competencies. It's also useful for designing continuing education to understand where the gaps are. And so what are the courses that people might need to build their skills, the kinds of experiences they might need to have in supportive supervision to build better skills. And then individuals themselves can also develop a personalized education plan to know, where am I deficient? How can I strengthen my skills in going forward? So where do I need better continuing medical education, for example, to move my skills forward? We hope to have this toolkit out for you within the next couple of months, and hope that it will actually be a key step in moving us forward to not just training people, but actually making sure that they have the skills and are actually able to provide the services that they need in care. Thank you very much for your attention. Next slide. With that, I want to turn it over to Nina to talk about our next steps in the model chapter in pre-service education. Over to you, Nina.
Thank you, Larry. It's an exciting development, and it is exciting to see that there are more and more tools becoming available over the next couple of months. So I'd like to speak to you today about the infant and young child feeding model chapter for medical textbooks for allied health, for medical students and allied health professionals in the second edition. Many of them are can I have the next slide, please? Many of the mothers whose voices we heard today report experiencing significant gaps between the evidence around effective breastfeeding management and care and what happens during their interactions with clinicians. Many healthcare professionals lack confidence in breastfeeding support, which is hardly surprising when so many of them report receiving minimal education or training on infant and young child feeding in their pre-service programs. To address this challenge, the model chapter was developed in 2009 to promote the integration of evidence-based clinical education on infant and young child feeding in the basic training of healthcare professionals. In addition to providing a grounding for health professionals, the model chapter has become a reference where readers can find WHO recommendations summarised and applied in a single handy volume. Next slide, please. Knowledge supports competence, thanks to Nat. It is essential for providing quality care. It informs sound clinical judgment and it initiates an orientation towards lifelong learning. Since the model chapter was first published in 2009, WHO has revised and updated several guidelines relevant to infant and young child feeding, which means that more healthcare professionals must develop competencies that enable them to support breastfeeding in a variety of contexts, including antenatal and postnatal care, paediatric high dependency and intensive care units, in routine well child care, and in nutritional treatment programs, for example. Next slide, please. The second edition of the model chapter, which will be available very soon, and we will send you the links as soon as it becomes available, has been reorganised to reflect clinical practice. It has been designed to support routine breastfeeding support It incorporates new public health priorities. It is updated with all of the latest WHO recommendations and includes for each section key messages highlighted to make it easy for people to give themselves a reminder when they're in practice. Next slide, please. There are 8 sections in the model in the second edition of the model chapter. The first is the introduction, which contains the recommendations, some health outcomes, epidemiology, and discussion of policy frameworks, anatomy and physiology, and explanation of information about how breastfeeding works. A chapter on complementary feeding that gives evidence-based guidance, a chapter on perinatal care that includes discussion of the 10 steps to successful breastfeeding, and a number of other issues that are relevant to perinatal care. Community breastfeeding support, so supporting breastfeeding beyond the perinatal admission, a discussion of how to support breastfeeding in special breastfeeding situations, including emergencies in the context of infectious disease, malnutrition, relactation, cancer treatment, and others. It describes common challenges and how to identify and manage those. And it also has a new section on routine guidance for that health professionals can give to mothers. Next slide, please. Incorporating evidence-based clinical education on infant and young child feeding in basic training for healthcare professionals is an investment in the future. This World Breastfeeding Week, we are calling on medical educators to use the model chapter to integrate infant and young child feeding into pre-service curricula for healthcare professionals, to align policies, protocols, and practices with WHO recommendations, to inform evidence-based breastfeeding support and management, and to support professional development in the context of in-service training and continuing professional development. I hope that it will be useful to you all, and we would love to hear how you are using it in your countries and in your programs. And with that, I will hand back over to Altrina, who will continue us on our journey this morning.
And this afternoon.
This afternoon.
Thank you, Fatmata, Larry, and Nina for those excellent presentations. These valuable tools and resources give us concrete ways to ensure that healthcare staff competency, from monitoring the delivery of quality breastfeeding counseling and support, to verifying their skills and practice, to building foundational knowledge and skills from the start of health professional education. Thank you so much. And I'm so glad those tools are available, or will be available, that will be able to support countries and programs. We look forward to sharing these links with you. As previously mentioned, the materials will be sent to all of you registered attendees via email in the very near future. So next, we have a 4-person panel. Now you've heard about some wonderful tools that are out there, and toolkits and resources, but let's hear from the countries about how are they going about strengthening the delivery of breastfeeding support in national and subnational healthcare systems. They will also advise us how the new resources may be applied in their country context. So we'll start with Dr. Maria Elena Guevara. She is a senior official at the Ministry of Health in Honduras, the Department of Secondary Level Care Services. Dr. Guevara is a medical doctor, graduated from the National Autonomous University of Honduras with a background in public health. She holds a master's degree in epidemiology with over 30 years experience. Then we have Ms. Ruvi, sorry, I went in the wrong order. Anyway, we have, you can follow, see if you're awake. Ms. Ruvi Guzman is the acting undersecretary in the Secretary of Health Promotion, Intercultural Health, and Equality in Ecuador. Ms. Guzman holds a Bachelor's of Science in Nursing, specializing in integrated quality management, and a Master's in Healthcare Quality Management and Patient Safety. Ms. Guzman has held numerous senior management positions in the Ministry of Public Health in Ecuador. Next, we have Dr. Mariana Colmenares Castano, who is a Mexican national who lives in London, where she works as a community pediatrician. Dr. Colmenares has worked in breastfeeding medicine since 2011 and is currently serving as the secretary of the Academy of Breastfeeding Medicine. She also is a professor of the breastfeeding counseling course at ACLAM, which is the National Association of International Board Certified Lactation Consultants in Mexico, and COA, the National Organization of Nutrition Education. And last but not least, we have Mr. Mark Andrea Jovo. He serves as the Deputy Director of Nutrition in the Ministry of Health and Childcare in Zimbabwe. Based in Harare, Mr. Njovo oversees national nutrition strategies, monitoring, and emergency nutrition responses. He has contributed to several peer-reviewed studies under the Ministry of Health and Childcare and has worked on various nutrition researches in the country. Welcome to our speakers. Now let's hear directly from them about their experiences strengthening breastfeeding support in healthcare systems in the Americas and Africa. Let's start with Mexico. Mexico has made significant progress in embedding breastfeeding into its healthcare system through training, regulation, and strategic alignment with national health priorities. Dr. Colmenares, can you share with us how Mexico embedded breastfeeding support into the national healthcare system, and how has that health system ensured that health professionals maintain their knowledge and skills over time?
Yes, thank you all. Well, there are many things that have been done in Mexico in the last years. I've been working in breastfeeding for the last 15 years around, and there has been interesting changes in breastfeeding that went from 14% to 34% in the last health survey. And I think that there are a diversity of strategies. There's a good team of researchers. There is interest in, there is a national interest. There is a development of the national breastfeeding strategy, and the new national committee that they are implementing and trying to put together a lot of breastfeeding and mainly around training healthcare professionals. So I think it's quite complex to talk about just a few things, but research and training and strengthening the baby-friendly hospital initiative. One of the most important things that they have been doing is around the code and the monitoring of the compliance of the International Code of Marketing, which is one of the most important reasons why Mexico can have such difficulties around breastfeeding. It's very, very difficult for parents and for moms and families to really have good breastfeeding support if they still have this counterpart of all the industry. So it's about campaigns, marketing campaigns, and research in between the health care professionals and training. So yeah, it's.
Thank you. So let's move on to Honduras. Honduras has revitalized and is scaling up the baby-friendly hospital initiative nationally since 2022. So they are moving in this direction, and they're very well versed. My next question is to you, Dr. Guevara, is what advice do you have for countries based on lessons learned by Honduras in integrating breastfeeding support into the various levels of national healthcare system? And what strategies do you feel have worked best in Honduras?
Bueno, las estrategias que a nosotros nos han funcionado mejor es, uno, siempre mantener activo lo que es la Comisión Nacional de Lactancia Materna, como país donde la integran las diferentes instituciones que tienen que ver con el TOC. Luego de eso, tener un plan nacional de lactancia materna, donde cada institución ve identificado dónde se ubica el quehacer de ellos. Y el tercero es contar con una política nacional de lactancia materna. Nosotros eso nos sirvió y nos ha servido para lo que es la estrategia Hospital Amigo de los Niños, porque dentro de la estrategia están los 10 pasos. ¿Y qué logramos? Que cada hospital adaptara elaborara su política, la actualizara. Entonces, cada uno de los hospitales, de las 26 hospitales que brindan atención materna, cuentan con una política que fue elaborada al interior de ellos. Eso ha sido vital. Luego de ello, mantener activos y la reactivación de estos comités hospitalarios de lactancia materna, que son los que vigilan, los que monitorean e implementan cada paso. Y en cada comité de cada hospital hay un coordinador que está manteniendo activo, que está estos comités, que está vigilando, que está bajando, que está monitoreando con los instrumentos que ustedes propusieron. Allí ellos con entrevista verifican con el personal y valoran lo que es la capacitación. Y luego se desarrolló una plataforma virtual para que los personal que brinda atención tuviera acceso a estas capacitaciones. Y luego verificamos en campo que en realidad están poniendo en práctica lo que aprendieron. Eso ha sido en forma general vital para que estos países, para que esta estrategia de hospital amigo de los niños funcione en este país y que se volviera a reactivar y a recertificar a los hospitales como hospitales amigos de los niños. También estamos y lo recomendamos, son estos instrumentos que ustedes están proponiendo, que son efectivamente vitales, ¿verdad? Para la implementación y para el monitoreo de estas iniciativas que son efectivas y obviamente logramos que los hospitales se apropien de ello. También trabajamos con las universidades, con este nuevo recurso que está saliendo, esta nueva generación. Y entonces se agarran y se implementa con la universidad. Desarrollamos todo este tema y ha sido incorporado en la currícula de los estudiantes, porque esa era una debilidad que nosotros siempre mirábamos y tenemos cada vez que estos recursos se incorporan a nuestros sistemas de salud. Entonces fue una forma de que ellos ya vayan capacitados para poder brindar esta atención. Obviamente estos cursos también están dispuestos en una plataforma donde el estudiante puede reforzar estos conocimientos. Con las universidades también hemos desarrollado lo que es un diplomado para la gente que está ingresando al sistema de salud. Entonces se les está como exigiendo que saquen este diplomado para que ya salgan preparados en estos tópicos y para que ellos puedan continuar y darle sostenibilidad a estas estrategias. Y lo otro que quería comentarles es que estamos actualizando lo que son los protocolos de atención. Acabamos de actualizar lo que es el protocolo de atención al neonato, donde tomamos todo un capítulo que nosotros no lo teníamos sobre lactancia materna en estos niños. Se desarrolló y se tomó, obviamente, toda esta bibliografía que ustedes están poniendo, la alimentación del niño y de los niños pequeños. Entonces se tomó y está dentro de los protocolos. Estamos en el proceso ahorita de actualización de lo que es los protocolos de atención de nutrición para el personal que trabaja en primer nivel, ¿verdad? Donde obviamente vamos a tomar en cuenta, por eso lo recomendamos, esta bibliografía que ustedes nos están proponiendo, ¿verdad? Nuevamente lo vamos a revisar y adaptarlo a nuestro país sobre la alimentación de los niños pequeños, de los lactantes y los niños pequeños.
Thank you so
Entonces,
much.
ese es el camino que nosotros estamos siguiendo y que nos ha dado mucho, y lo recomendamos, nos ha dado muchos resultados.
Thank you so much. Thank you so much. That was quite comprehensive. And we really appreciate all that you have been doing there in Honduras to integrate and to sustain breastfeeding counseling into your country program. And talking about monitoring, I'd like to move on to Ecuador. Ms. Guzman, you have a background and experience in quality improvement and health service auditing. And I think you are best positioned to tell us about how what Ecuador has been doing to ensure the quality of breastfeeding counseling and support and monitoring the competency of health workers.
Buen día a todos. Sí, Ecuador prácticamente viene trabajando también con los procesos de certificación de establecimientos de salud, amigos de la madre y el niño. Acá le denominamos la estrategia ESAMI. A través de esta estrategia, nosotros hemos estado implementando algunas prácticas de atención, entre las que tenemos 3 básicas en el proceso de atención del parto, que es el apego piel a piel, el clampeo oportuno del cordón umbilical y la lactancia materna en la primera hora de vida, que se promueve con todos los profesionales de salud, tanto del ámbito público como del ámbito privado. Entonces, este año prácticamente estamos trabajando también ya con los establecimientos de salud del ámbito privado y de otros prestadores públicos que tenemos dentro de nuestro país. A través de la estrategia SAMIN también nosotros promovemos el tema de la consejería en lactancia materna a las madres mediante una preparación previa durante las atenciones prenatales que se realiza en los establecimientos de salud del primer nivel. Entonces, aquí estamos promoviendo los grupos de apoyo a la lactancia materna, que prácticamente se basan en dar una consejería previo al parto de cómo se debe brindar o dar la lactancia materna a los niños, lactancia materna exclusiva durante los primeros 6 meses y también procesos de alimentación complementaria. Adicionalmente, como Estado, nosotros tenemos una ley de apoyo y fomento a la lactancia materna desde hace años atrás, y durante el año 2020 nosotros también desde el Ejecutivo, que fue nuestro presidente, se creó la Estrategia Nacional Ecuador Crece sin Desnutrición Infantil, que se aprobó con el Decreto Ejecutivo 1211, y posteriormente en el año 2022 se reformó este Decreto Ejecutivo con el 404. En el 2022, este promueve el otorgar un paquete priorizado de bienes y servicios dirigido tanto a las gestantes como a los niños y niñas menores o hasta los 2 años, que nosotros consideramos el año 11 meses, 29 días. Uno de los componentes esenciales de este paquete que tenemos nosotros como el paquete priorizado es la consejería en lactancia materna y el tema de la alimentación complementaria posterior a los 6 meses, que debe brindarse de forma continua y registrarse como parte del proceso de atención. En este paquete nosotros estamos desarrollando a la fecha una evaluación con estándares de calidad mediante una herramienta de evaluación cruzada, pese a que tenemos también algunos dashboards donde están indicadores clave, y entre uno de ellos es la evaluación a la consejería de la lactancia materna. También estamos implementando otros, como por ejemplo el tema de las vacunas, el tema de la atención y la alimentación complementaria. Esta consejería ha pasado de ser una prestación como un cumplimiento con el seguimiento a través de sistemas de información y una evaluación periódica que realizamos en el talento humano de salud a nivel nacional. Además, el personal de salud es capacitado a través de módulos estructurados y metodologías adaptadas, lo que permite garantizar un enfoque integral que combina evidencia técnica, pertinencia cultural y atención respetuosa, porque en nuestro país nosotros también tenemos varios pueblos, varias nacionalidades, entre ellos tenemos los indígenas, los Ashuar, los Awá, entonces nos toca adaptar las cajas de herramienta de capacitación a cada una de estas de estos requerimientos específicos que tenemos con estos pueblos. También nosotros impulsamos espacios comunitarios. En estos espacios comunitarios tenemos los grupos de apoyo a la lactancia materna, las salas de apoyo a la lactancia materna que ya habíamos hablado. Estos grupos están liderados por personal de salud y también por madres consejeras. Ecuador ha tomado la iniciativa de justamente no dar una charla magistral, sino que sean las madres las que se empoderen y den sus conocimientos, los compartan con otras mujeres que van a iniciar o van a estar en su proceso de lactancia. También promovemos el acompañamiento familiar, que esté el padre, que esté la madre de la mujer, de la gestante, desde el primer nivel de atención. Estos espacios para grupos de personas son con necesidades afines que se reúnen periódicamente para compartir vivencias y conocimientos apoyándose mutuamente. Entonces, de esa manera, también promovemos esto de la atención centrada en la persona, donde ya sean actores activos para promover el tema de la lactancia materna. Ese es el trabajo que ha venido realizando Ecuador.
Excellent. Thank you so much. I think our panelists are so excited about sharing their country experiences, and they're so interesting. Thank you so much, Ms. Guzman. I just want to let you know that I'm asking for 2 minutes each time. We're going to come back to you again. You'll be able to answer some more questions, so you get more time to speak. So, Mr. Jovo, in Zimbabwe, we understand that Zimbabwe has embedded breastfeeding support at both the facility and the community level. Ms. Guzman was starting to bring us in on how Ecuador is doing that at the community level, but maybe you can let us know more about how in Zimbabwe you're connecting that hospital community level to overcome some of the challenges that mothers have once they get back home.
Thank you very much. So I would say as a country, our health system is designed in a way that we have community health workers that report to the nearest health facility coming from the communities that they reside in. And what we've done is we have worked in a way that we train these community health workers to be able to provide health services, at least at the primary level health service, and that is inclusive of breastfeeding support or infant feeding support. We utilized the community infant and child feeding module from UNICEF and WHO that we have given these community health workers. So their role is really to when we discharge mothers from our institutions, they are automatically referred to their nearest health worker, who then does community visits to home visits to these mothers or to these new mothers, and they are then able to discuss with the mother, support the mother on any challenges that they will be facing with regards to early breastfeeding issues that is made within the first month, and even going beyond to up to 2 years. So this, in a way, is made the support more community oriented, because these are people that they live with on a day-to-day basis. It's like your neighbor coming to support you. So they are the people that are doing that. But also, what we've also done is we are seeing that we have got a limited number of village health workers. We are also utilizing the care group model, which then also increase the reach of these support systems, where we train lead mothers who are then also increasing the coverage. But beyond the health system, we also engaged our local leadership. These are the chiefs, the traditional chiefs. They are also custodians in terms of giving out information. So when then the village elder comes in with the support, it's something which is taken up because the chief is also maybe supporting or speaking about the importance of breastfeeding. And also we have also reached out to other ministries beyond the health. We've got agriculture, we've social welfare. We have also given some form of capacity in terms of being able to communicate about how important breastfeeding is to the development of the nation and also to the development of their communities in terms of health and other things. Thank you.
Thank you so much for informing us about Zimbabwe, and thank you for sticking to your 2 minutes. We'll come back to you to hear more about Zimbabwe. Now I want to go back to Mexico, and Dr. Colmenares, can you tell us some of the challenges that Mexico have encountered in institutionalizing breastfeeding support within the medical and allied health professional training, and what strategies are breastfeeding using to overcome those challenges, to strengthen training, and if the tools that you heard today would be of any use and how they might be used in Mexico?
Yes, thank you. Well, challenges, I think that there have been many, but the people that work around, like the National Institute of Public Health and UNICEF and the Association of Lactation Consultants and the Academy are really doing a hard work, trying to convince others that are not as convinced about breastfeeding. I think it has been quite difficult and it takes a lot of time. And what I told before about the code. So there's a new AI tool, which is amazing. And I think it has so much work behind it to report the violations of the code, which is Código Lactancia, and it's online already and it's working. And I think that Mexico is a pioneer on that because we really want to change things there. So that's an interesting tool, how we have overcome that, but it's still quite difficult because Mexico, I think that the investment, and it's not just in Mexico, I think that's something that happens in many places in the world, that they don't see that the real need of investing in breastfeeding and breastfeeding support and counseling. And about the tools, well, that's a very, very difficult question because I'm in love with the training one because I train myself. I
Tell
love
us about the
training.
training one then. That's good.
Yeah, and I think that really training healthcare professionals before the service is one of the main tools that will change breastfeeding, because we can do a lot of things after that, but we are like navigating against so many things that are not well known, and people do things that are not evidence-based. But when you have a group of students that are learning about breastfeeding and understanding a breastfeeding, they really come and change. They can change services. You don't need to talk about again things. You don't need to like try to get rid of the malinformation they have been receiving. So the tool that I think it would be very, very interesting, and I think that the people that are in charge of training in Mexico are really using evidence-based information, but it's difficult to start. Like sometimes I think that scaling down can be a difficulty. We have good research, we have good documents, we have all that, but then scaling it down to get to the families and to moms and babies directly. So also the competencies will be also a very, very interesting tool to use. And I'm sure that my colleagues in Mexico, we will start using them right away. So yeah.
Thank you. Thank you so much, Dr. Colmenares. It's great to hear how these things could be applied in the country context. Now, can I move on to Dr. Guevara? Again, can you please stick to 2 minutes? And maybe you can tell us a little bit about how how Honduras is investing in training of medical and allied professionals in breastfeeding counseling and support. And then also if you can talk
Nosotros
about
estamos,
application.
bueno, nosotros estamos invirtiendo, que se ha desarrollado un trabajo mutuo con la universidad. con las escuelas, ¿verdad? Formadoras de recursos. Entonces, se han desarrollado, como dije, estas plataformas. Durante nosotros vamos con los hospitales, les proporcionamos ese link para que ellos puedan entrar. Una vez que ellos están preparados, que ya su personal está capacitado, a nosotros nos dicen ya estamos preparados, pueden venir a hacer una evaluación. Nosotros vamos con los instrumentos adaptados que ustedes propusieron, se adaptaron a nuestro país. Vamos, hacemos la evaluación, verificamos y luego tenemos como una doble. Se hace la entrevista con los proveedores de salud, luego se hace la entrevista con las madres que han tenido su bebé ahí en el servicio y luego lo verificamos cuando vamos en algunos pasos que se propone con la observación. Esa es la forma de que nosotros trabajamos. Luego tenemos, hay plataformas donde el personal también que quiere avanzar, se matricula en el diplomado. El diplomado tiene 120 horas y los que se meten, estamos monitoreando que terminen su curso y luego lo verificamos cuando nosotros vamos nuevamente, que vamos a entrar a una nueva fase, que es el seguimiento y el monitoreo de esto. Ellos lo hacen, pero nosotros bajamos como nivel central y lo verificamos.
Thank you so much, Dr. Guevara. I think that verification tool will be very useful in Honduras because already you've made such great progress in the training of your medical and allied health professionals in breastfeeding counseling and support. And I hope that you will find that verification tool useful as you move those graduates out into their workplaces. Next, I'd like to talk to Ms. Guzman. In Ecuador, I understand that Ecuador has made great progress in scaling up access to donor human milk in hospitals. And so maybe you can share with us about the link and the establishment of integrating the breast milk banks into the norms for breastfeeding counseling and to ensure that mothers of preterm and sick newborns have access to donor human milk and improve their exclusive breastfeeding as well. And again, 2 minutes, please, so we can cover everybody. Thank you.
Sí, Ecuador tiene una experiencia en la implementación de bancos de leche humana que están plenamente integrados en los servicios hospitalarios como parte del modelo de atención neonatal. Estos no solo recolectan, procesan y distribuyen leche humana donada pausterizada, sino que también son centros de promoción y consejería especializada en lactancia materna, alineados a la normativa nacional. Tenemos un manual de esta normativa. Desde el ingreso de un recién nacido, prematuro o enfermo, se activa el protocolo de consejería de lactancia materna a la madre para el inicio de la extracción y establecimiento de lactancia materna. Cuando la lactancia materna directa no es posible, se garantiza el acceso gratuito a leche humana pausterizada sin generar costos para la familia. La vinculación de los bancos de leche humana con la consejería ha sido fundamental para mejorar los indicadores de inicio temprano de la lactancia a través de los establecimientos de salud amigos de la madre y el niño. También se estableció como obligatoria la formación continua del personal de salud que atiende el tema de los partos y también que está en las salas de recuperación como prácticas integrales del parto, como ya se había hablado anteriormente, que es el tema del contacto piel a piel, el tema de la lactancia materna exclusiva en la primera hora de vida y el clampeo oportuno del cordón umbilical. Actualmente nosotros tenemos el 92% de los recién nacidos institucionales que reciben lactancia materna en la primera hora de vida. Este es un dato del MSP al 2025. También se fortalece la continuidad con consejería posalta, es decir, cuando ya se van a su casa, articulando con el primer nivel de atención, hacemos la contrarreferencia y con las salas de apoyo a la lactancia materna. Ese ha sido el trabajo de Ecuador.
Thank you so much. That's very interesting. I think that Ecuador has made great progress in making sure that babies have access to breast milk and not formula especially those most vulnerable ones in the early days of life. To Zimbabwe, Mr. Jovo, maybe please tell us what Zimbabwe has done to embed breastfeeding support within the training of maternity and child health service providers. From your experience, what would you advise other countries that are also challenged with some of the human resource challenges to maintain that lactation support capacity and competency of health workers?
Thank you very much. So I think what we've done basically is we've probably different groups of healthcare workers. For our nurses that are probably maybe designed to be working in the rural areas, which we call primary care nurses, they in their curriculum they have a 1 week allocated in terms of being able to receive the comprehensive infant and child feeding training course, where our nutritionists, our trainers go into the school and provide this training. And this, in a way, is provided us with a pool of health workers that are able to deliver on IYCF counseling and support within their health facilities. But also we have also done trainings in terms of post qualification trainings utilizing the same tool, of course, with support from partners such as UNICEF, WHO, and others, where we have also built capacity of our health workers to be able to also provide. But also we have nutritionists who are based at district level, provincial level, going in and providing on-job training and support to our service providers on a day-to-day basis, where they go in at a facility, they discuss with the service providers on how they can improve on their infant and young child feeding support to their mothers. But also, I would say one of the things that we maybe has helped us is having indicators that speak to the provision of these services within these service delivery points, where we are now talking about the proportion of mothers we have initiated breastfeeding in the first hour as part of the routine indicators that are reported. The proportion of mothers that have received IYCF counseling, be it at community level or at facility level, being reported on a daily or on a monthly basis. And this, in a way, has also helped us in terms of keeping our health workers on their toes in terms of being able to provide this service. So as advice, I would say, let's train, but also let's have some feedback mechanisms that speak to the actual provision of the service. In that way, you are in a way, there's a forcing or encouraging the service providers to be doing it, as well as then be able to report. And even when you come as support systems, you're also checking on that, and in a way, you're also training them on job. Thank you.
Great, thank you so much, Mr. Jovu, with that encouragement of forcing. We do that in pre-service, and that's what they signed up for. So we want them all to be able to do their jobs and do them.
Yes, yeah.
And so now we have concluded the panel section, but we're opening it up now for you participants to send in your questions, which you have been doing, and so that the panel and open it up to our presenters to be able to answer some of your questions. I know you're sitting on the ends of your seats to hear what they have to say. We're going into the Q&A. There you go. There's the button. You click there and you can put your questions in, and we will try to address them over the next few minutes that we have left. So one of the questions that has been brought to my attention is, how will countries monitor progress towards the 2030 target of 60% exclusive breastfeeding and the new progress indicator percentage of mothers receiving breastfeeding counseling now that the DHS is no longer funded? Will UNICEF's multiple indicator cluster surveys continue, and will this be sufficient? This is going to our UNICEF colleagues. Help in this time.
Yeah, thank you, Altrina. I'll just respond to that. Yes, UNICEF will continue with the multiple indicator cluster surveys, even as the DHS phase out in some contexts. But we wouldn't be able to make up for all the DHS. But in fact, UNICEF has just launched the Mix 7, the latest round of the program, which includes expanded content, flexible questionnaires, as well as innovations like Mix Plus. So we will continue to do this, but we will definitely not be able to fully cover all what the DHS has been doing. Thank you, and over back to you.
Thank you. Having previously, in a previous life, worked for the DHS, it really breaks my heart that they will no longer be there, but I'm so happy to hear that UNICEF is picking up the mantle and will do its best to cover these key indicators that countries need in order to monitor and to sustain their breastfeeding indicators. Another question that's been brought to me is, someone said, I'm wondering how you get around the challenges of low pay that community health workers often experience, which then results in high staff turnover and ongoing training. In Zimbabwe, Mr. Jovel, are community health workers paid at least the national minimum wage, or is it a voluntary role that attracts a stipend?
Okay, thank you for the question. Our community health workers are recruited on a voluntary basis, where communities identify a person whom they feel is capable and would be amenable to them in terms of providing them with community health services. So it's strictly a voluntary position, where of course there's a little bit of something that they get, but it's for me to say whether it's meeting the minimum wage or so. I'll have to check, but it's strictly a voluntary position which they take based on the communities they are coming from, and they are identified by the communities that they are identified from.
Thank you. Another question that's been brought to my attention is some governments claim that implementing the 10 steps is not feasible. Can any of the panel members share what drove their governments to commit to implementing the BFHI and the 10 steps? Maybe Dr. Guzman or Dr. Guevara, maybe you can talk about how your countries, how Honduras or Mexico has committed when some people have doubts.
Bueno, nosotros, como le dije anteriormente, lo hicimos y hay algunos pasos que han adelantado con otros, obviamente. Pero los 10 pasos se cumplen. Primero se capacitó el personal. Nosotros luego agarramos la estrategia y hemos trabajado paso a paso con cada uno de los hospitales. Entonces, trabajando cada uno de los pasos. Hay algunos, como digo, que obviamente no están al 100%, porque nosotros, por ejemplo, incluimos a los hospitales amigos de las madres, niños y niñas. Y obviamente los servicios tendríamos que acomodarlos para que cumplan lo que es parto seguro. cuando en algunos aspectos nuestra sala, nuestra infraestructura no está como para permitir, por ejemplo, que se deje un acompañante, porque hay que respetar los derechos de las demás. Son salas comunes y yo no puedo permitir que el padre acompañe a la madre a donde se le está atendiendo el parto, porque tengo otras mujeres también que están en el mismo proceso, están en el proceso de expulsión de parto y no puedo, hay que respetar el pudor. Por eso dije, vamos a adaptar algunos espacios, algunas cosas mientras nos preparamos como país para que cumpla. Estamos trabajando el otro paso que tenemos y teníamos dificultad y estamos trabajando con la red de primer nivel. Por ejemplo, es asegurar la lactancia materna exclusiva a los 6 meses. Entonces, estamos trabajando con con los primer nivel para que ellos impulsen, sigan trabajando con estos grupos de apoyo para que pueda darle seguimiento a esta paciente. ¿Por qué? Porque esta paciente, para la coordinación de la red, porque estas pacientes, por ejemplo, tienen su niño, se van, y entonces ese es el trabajo que estamos haciendo con primer nivel para que ellas puedan darle continuidad a todo este proceso. Así estamos trabajando. En este paso, obviamente, claro, ellos no han avanzado mucho, pero lo estamos desarrollando y estamos trabajando con la gente de primer nivel e inclusive para que ellos, que es donde las mujeres asisten a sus controles prenatales, trabajen desde que la capten hasta que llega a tener su niño al hospital.
Thank you, thank you. It's very good to hear how Honduras has that commitment, and maybe countries are encouraged that you can work on those 10 steps and you can ensure that mothers get adequate support from prenatal through the first 2 years, and particularly during the connection with the hospital during the perinatal period. One question, last question, and the responder, please be very brief so we don't run out of time. How are mothers whose babies are given DHM, donor human milk, supported to ensure they are able to be discharged breastfeeding? Ms. Guzman, that's an important lesson that I think Ecuador has learned and can share with us, that although you are making sure these newborn, these preterms and these sick babies are getting donor human milk instead of formula, but how do you ensure that once the mothers are discharged, that they are able to exclusively breastfeed? Thank you. 2 minutes, please.
Bueno, nosotros hacemos el tema de la consejería de la lactancia materna, como se les había mencionado, desde el tema de los controles prenatales. Luego también en el momento del nacimiento hacemos la continuidad de este previo al alta. Volvemos a hacer capacitaciones con las mujeres embarazadas y también implicamos a la familia, a su círculo familiar. Los bancos de leche humana funcionan estratégicamente en varios hospitales a nivel nacional, los que han sido priorizados, donde existe mayor necesidad o demanda de leche materna, justamente en mujeres y niños que no van a poder brindar una lactancia materna por parte de su madre. Entonces, estos funcionan todos los días, se hace grupos de apoyo que son donde pueden acudir de manera diaria a solicitar la leche materna. Nosotros tenemos el procesamiento diario de la leche donada y tenemos mujeres que diariamente donan leche. Entonces, es un proceso sostenible en el cual nosotros podemos otorgar leche materna exclusiva durante los primeros 6 meses de vida. A la fecha no hemos tenido inconvenientes. Todavía nuestros bancos responden a la necesidad actual y estamos planificando la implementación de más bancos, sobre todo en el sector público, que es el gobernante de la salud en el país y el mayor prestador. Entonces, hasta la presente fecha generamos un recurso permanente que se otorga en estos niños y madres que no pueden brindar leche materna exclusiva a sus niños durante los primeros 6 meses de vida. Luego se complementa con el tema de alimentación complementaria y hacemos el seguimiento con la entrega del paquete priorizado, que acá tiene algunas características como la entrega de vitamina A, el tema de los controles cada mes hasta cumplir el año y posteriormente los controles cada 2 o 3 meses hasta cumplir los 5 años de edad. Entonces, es un flujo que lo mantenemos de manera permanente y una vez que el niño ingresa a este sistema de entrega de leche, pues hacemos el seguimiento constante. Ahí creo respondí a su pregunta.
Thank you so much. And we're running out of time. Let's move on to the next one. Thank you so much, panelists, for your thorough answers. I'm sorry we couldn't get to everybody's question, but I hope that this we're able to address some of these questions that you had in mind. And I want to give a big thank you before we leave today to the Global Breastfeeding Collective Webinar Task Force. You can see there are too many names to mention and organizations, but you all have been valuable in supporting and planning this webinar, this excellent webinar, and we are most grateful for your support. The next slide, please. So we have a call to action as we wrap up. 2 minutes over, but if you can stay just 2 more minutes, let's review these call to actions. Now, what are you going to do now that you've heard all of this and you've shared and you've questioned? First, we're going to strengthen healthcare system accountability. That's what we're calling. We must build a robust internal monitoring systems that hold healthcare facilities accountable for providing appropriate breastfeeding support and counseling to mothers throughout their journey. Second, we want to ensure that healthcare staff are competent. So to ensure their competency, this means investing in building the capacity of healthcare staff by ensuring that they have adequate competencies to provide the skilled breastfeeding counseling to mothers, right? That is not just information, it's not just education, but real help and support, as we see in this picture, so that moms can successfully breastfeed. And third, allocate dedicated funding, right? We have all of the commitments, we have all of the policies, we have all of the regulations, the guidance, the monitoring, the tools, etc. But we need secure, sustainable funding to implement and maintain these healthcare system improvements, including staff training, monitoring systems, and ongoing competency development. Next slide. So finally, I want to say thank you to all of you for joining us and staying the couple of minutes over. Best wishes for a great rest of your day, afternoon, and evening. And as I open, let's close with this commitment. From the womb to 2 years of life and beyond, together, let's strengthen the quality and sustainability of breastfeeding support throughout the healthcare system. Good day, everybody.
Buen día y hasta luego.
Good day, everyone. Thank you.